Well, top of the evening to you and happy holidays to everyone. It is that time again. It is 5 o'clock p.m. On the Gulf Coast, which means 4 o'clock in the mountains, 3 on the West Coast, 6 on the East Coast, and there is only one place that you are supposed to be right now, and that is right here. My name is Dr. Randy Fink, and this is Fertility with Fink, live from Pensacola, Florida. We also have offices in, Mobile, Alabama, and Panama City. We see folks from all over the country, and we are happy to be here this evening, talking to people really coming from all over this great nation of ours, as well as we typically have a couple in the Caribbean as well. And I think even once we had somebody from South America. So wherever you are tonight, it is a pleasure to have you here on this wonderful Tuesday evening, the eve before the eve, and this is the time that lots of folks will have a very special party tonight, the eve before the eve. And if you're partying up tonight, or if you're just at home waiting for Santa to come along, that is good, because he is getting his sleigh all loaded up and ready for you and for me and for all of us who are on the nice list, not the naughty list this year. If you're joining us here, we've got three different feeds here, or actually, we've got three different cameras here. We've got Facebook, LinkedIn, and YouTube right here. And we've got my Instagram, Randy Fink MD. Here's New Life Fertilities right here on the Instagram side. And again, so happy to have everybody here tonight. Amber, good evening. I will answer. I saw you texted, and I will answer back as soon as we are done there. Hello to Jazzy Poo. You are number one on my Instagram list tonight. Thank you for being here. The first for being here. The wonderful Bamagal and Pal. That is my mom and dad in Mobile, Alabama. Thank you for being here, and good evening to you. Bailey is with us tonight, as is Rosa. Hi to Angela. Rosa, thank you for your kind words here, useful and uplifting. It has helped me a lot. I'm so happy to hear that, and it helps me to get that kind of feedback coming from you, because that makes all the difference in my world. I was having a conversation with a very nice patient today, kind of about all the different ways that kind of healthcare has changed over the course of the last couple of decades. And really, we look for things to be collaborative. Now, to me, it's about the relationship. I take personal pride in the kind of service that we're able to provide, and that's it's a constant battle. It's a constant work, to really try to exceed expectations, because I think that's probably different than the way things were in the decades past. And that was that you had a doctor's office, and you went to the doctor's office, and really, what you got out of that was your problem. The doctor was there as a technician and maybe provided the service, and how you took that information, they took no particular amount of pride in. And I generalize that. I don't know that that's entirely true, but I just kind of have a very different sort of look at things there. So really, just kind of want to try to do the best we can for every person that we run across, especially in this fertility business, because it's hard enough as it is to deal with these things, the emotions that go into the roller coaster of fertility, but also, to add human factors on our end, where we're not perfect, and those things, can really create hard conditions for people having to go through treatment. So I really feel strongly that we should all be trying the best we can, so that we give the very best experience to each of us, as humans. And that's why one of the things I talk about is every step forward with love, and every step forward with kindness. And at half past the hour here, we do the 5:30 Fuzzies with Fink, and that is where we all stand together as a community and send out good wishes to everyone who needs those wishes tonight. So hi to Raquel, and hey to Sarah, Elizabeth, thank you for being here tonight. If you guys have questions, feel free to throw them my way. That's what we're here for, to answer all your questions. And if we can't get to those, feel free to email me, and that's askfertilitywithfink at firstfertility.com, and we will try to get to those at the very top of the next show. Now, next week we will be off next week. There will be no Fertility with Fink in that week between New Year's and between Christmas and New Year's. So that is the 30th of December. We won't be here, but we'll return for our broadcast on January the 6th. January the 6th will be our next day. Hi, Mona Queen. Thank you for being here this evening. So I had a question actually that came from a guy. And you may be saying, what's a guy doing asking questions here? Well, men go through this process as well, and men have some particular kinds of issues. So sometimes we'll see men here who have had vasectomies and who are still hoping to be able to build a family, years gone after a vasectomy, most of the time with a new partner. And that's something that we can easily accomplish in most cases. So we do see men, a semen analysis is really a very regular part of the evaluation we do here. And there are some specific criteria that I look at as it pertains to a semen analysis. So the first thing is I look at what's called the TMC, or the total motile count of sperm. The total motile count means the total number of sperm that are swimming. So what happens is that our andrologists, or our technicians in the sperm lab, will do a count of the sperm that they see under the microscope in that semen analysis. When they have that, we got to look also at the volume of the sperm, at the amount really of semen that was produced, along with the percentage of the sperm that are swimming. So we look at a concentration, which is the actual count, and we look at the volume, and we look at the percentage swimming. Generally speaking, we like to see more than about 40% in general swimming sperm, and that we would consider normal. And that results in a total motile count. And what does that actually mean? It means that we, as humans, I tell people we are pretty inefficient with the way that we reproduce. Reliably, we need, really only one sperm to get the job done. It only takes one sperm to fertilize an egg, right? But in order to get that one sperm on target pretty reliably, we need 20 million sperm in order for that one sperm to be able to get there. So that's what we mean by the total motile count of 20 million. The other thing that we look at is known as morphology. Morphology is somebody's job is to look at sperm under a microscope. They spend all day looking under the microscope at heads and necks and tails of sperm, and can comment to us on what percentage of those sperm look normal. So here's a fun fact. As humans, 96% of our sperm, 96% of our sperm are expected to look abnormal. In other words, what's normal is that 4% normal forms is expected. 4% normal is normal. So a morphology of 4%, I'll have some people who get those results and they look at it and they say, oh my God, I only have 4% normal forms. Guess what? That's like every other guy. So sometimes I see people who have 10% normal forms and I'm like, wow, that's fantastic. That's incredible. What does that mean, those normal sperm? Well, the normal sperm are expected to function the way normal sperm would, and that is that they ought to be able to find a way to fertilize an egg. So when we see that there is a persistent amount of abnormal looking sperm, and that's what's called teratospermia. When we see that there is a persistent degree of teratospermia, we start to wonder, well, is this going to be an issue where the sperm have a hard time being able to retrieve? The sperm will have a hard time being able to fertilize an egg. And the answer to that is, yeah, possibly so. There is a test that we can do for that, and that's called an SDFA, a sperm DNA fragmentation analysis. What's the significance of that sperm DNA fragmentation? Well, as I always say, a sperm is really just a little package of DNA with a motor on it. That motor is the tail, and so we know what that looks like. But we can't say anything about the DNA that's in the sperm, right? The only thing we know is what's that sperm look like. So the most important thing that a DNA fragmentation analysis is supposed to tell us is whether that sperm has the capacity to be able to fertilize an egg through something like an IUI or an insemination. So a DNA fragmentation analysis comes back as either normal, or there are two other findings, something borderline or something abnormal. If it's borderline or above, then we start to think that, gosh, there's a sperm issue here that isn't going to be able to fertilize that egg. And in fact, that's what the data shows us. So that's one of the reasons that we may suggest to a couple that appears to have an adequate sperm count, but an abnormal morphology, that an IUI is not something that has a probability of working. So that's one way of us being able to determine who needs IVF instead of an insemination. The second thing is, well, usually in that situation, if we take that sperm and place it inside the egg, then that sperm will fertilize the egg, and that we're creating that fertilization event, and that creates your embryo. So the only other thing is that there are a few people who then will not be able to create chromosomally normal embryos with that sperm. Most of the time, doing the ICSI process, which is taking that sperm and placing it directly into the egg, is enough to overcome an issue with DNA fragmentation. But in some cases, it may not. We really won't know that until after the fact. And if that's the case, it is said that taking that sperm directly from the testicle through a procedure that's called a TESA is a better plan, because the thought is that sperm is getting scrambled somewhere in the system that allows it to escape, somewhere along the path, headed out between the testicle where it's manufactured during the process of ejaculation. That if we bypass that, then that can create more normal sperm, if indeed that turns out to be a problem. Let's see. I had a couple of questions, it looks like, about that here. And let's just say, let's see. Amber says, I had one failed FET. Should I consider inquiring about assisted embryo hatching next transfer? So assisted hatching is something that we typically do with every embryo. So you don't have to ask for it. That's something that we do kind of automatically. Hello to Zenny. Thank you for being here this evening. Good afternoon to you. Angela says, but in a TESA, the sperm is immature. And I would say, no, not necessarily. You may get some immature sperm, but you also get some mature sperm as well. You don't get as many as you would in an ejaculation, because in a normal ejaculation, again, we're expecting more than 20 million. So we may get something more like, 10,000 sperm. But even in that scenario, the embryologist is able to select an individual sperm for each egg. So that was an excellent question there, Angela. Excellent question. Good evening to MCRM Fertility, my friends up in the St. Louis area who say wishing all the best for the holiday season in the upcoming year. I also am very proud to do some work with MCRM in both St. Louis and Tulsa, and in that area, this is another really super fine group of people, really committed to doing the right thing for folks and helping people to get pregnant. Thank you for your kind words this evening, and happy holidays to you as well. Hi to Ruger and a Pleasant Hill supporter. Hello to Stephanie. AZ Signatures, nice to see you here this evening. Sicily's Daydreaming, I like the name. That's pretty good. What are your thoughts about using Pixie instead of Zymot for severe DNA fragmentation? So, good question there as well. So, Pixie is a different process for sperm selection. And there are some clinics, such as MCRM, for instance, you can elect to use up to really 3 different sperm selection methodologies. That would be Pixie, Zymot, and gosh, I forget what the other one is that they offer. But you can use other methodologies for sperm selection. Pixie is one such method. However, I've not seen overwhelming data that says Pixie is appropriate in the general population. And so therefore we typically recommend it. We actually here at New Life Fertility, we don't offer it. There are many labs that do not have the capacity to offer it. So it takes a special place even to be able to do that different type of technology. I can't see what that says, but it looks like BRNPT. How do you have a name, a handle there that I can't pronounce? I pick something easy so that people can look at it and pronounce it. But hello, good evening, and thank you for being here on the New Life side. Let's see here. Beads, thank you. MCRM is still listening. Beads was the other thing. So each of these is a different method for selecting a what is thought to be a better sperm to do the job. And so what we try to do there is to use some technology to select a better cohort of sperm so that an experienced embryologist can then still sit down and select an individual sperm for each egg. However, they are selecting from a cohort of better sperm to begin with. And I guess the thinking there is that when you can do 3 different things all in one sitting to select better sperm, then you really are potentially getting better sperm. Sarah says, I got my Receptiva results back, and my provider said 3 months of suppression if the value came back over 3. Is this what you'd recommend? I have mostly heard about 2 months. So Receptiva is a non-invasive test for an inflammatory marker that's associated with endometriosis. Endometriosis, as you may know, is the process where the uterine lining that normally sloughs off and comes out during a menstrual period instead works its way up into the abdomen and the pelvis. It can implant into the pelvis and create, in some people, a pain syndrome. It is a very well-recognized cause of severely painful periods. It can also be associated with some other type problems, pain with sexual intercourse, pain with the bowel movement. But to be honest with you, the most, those are the classic presentations of endometriosis, but the most common presentation of endometriosis is silent endometriosis, and that is endometriosis that we did not even know was there. That's really what BCL6 was designed to test for. It was designed to test for folks who have had embryo transfers, but who end up not getting pregnant when they should be getting pregnant. In that situation, we do this BCL6 marker. So it used to be that the only way that you could diagnose endometriosis was through a surgery, through a laparoscopy, right? Put a camera through your belly button under general anesthesia, look around, see if we can see endometriosis. We can now do that from a simple endometrial biopsy, and that is a test that's called Receptiva. It looks specifically for that marker known as BCL6. And when the BCL6 is positive, it tells us that you're going to have a hard time potentially implanting an embryo. How do we know that? Well, because if you have a euploid or a chromosomally normal embryo, then that embryo gives you about a 65% probability of achieving a pregnancy. If that BCL6 marker is positive, your 65% number drops down to really less than about 10%, unless we treat it. And if we treat it by hormonal suppression, and that's what Sarah is asking about, if we treat it with hormonal suppression, then we can take that less than 10% number and turn it right back up to 65%, as though your body had never had any awareness of that endometriosis whatsoever. The recommendation for treatment is 60 days. 60 days is what the evidence shows us is sufficient to negate that BCL6 marker and return your numbers, your success rate back up to normal. Now, some doctors may choose to treat you for longer than 60 days. They may say, well, in my experience, 3 months is better. There are some folks who ask me, well, can I do 1 month instead of 2? And I would say, you could really do whatever you want to, but the evidence shows us 60 days. Does using it for less than that accomplish the same thing? Maybe. In some people, it might. But again, the evidence shows 60 days. 3 months? Is 3 months any better than 2? Well, I'm not aware that they studied 3 months, 90 days compared to 60 days, but they studied 60 days and it showed that it returned your numbers to normal. Now, one reason some docs might suggest 90 days of treatment. And that is because one way that you can suppress that endometriosis is with an injection that is called Depo-Lupron. Lupron is the oldest medication that we have that allows us to treat endometriosis. It's been around for at least 30 years. And what it does is that it talks to the brain and it basically shuts down your hormones. Shuts down the hormones. It really puts you into a temporary menopausal state. And that hormone level that you're turning off is what the food supply is for the endometriosis. So in the absence of the food supply, the endometriosis kind of dries up and blows away, at least at the level of the uterine lining. It resets and clears out that inflammatory marker. So that's a good thing. That's a good thing. Depo-Lupron is a shot that lasts for 3 months. There is also a once monthly Lupron. It's a little lower dose, but you do it once a month, and you can do that twice, or you can do one single Depo-Lupron shot for 3 months, and that gives you 3 months of suppression. You asked there, Sarah, about the results, and you gave me a number. You said yours was 3.6, and your doctor told you if it was greater than 3, then 3 months suppression. Off the top of my head, I don't remember what the BCL6 positive threshold is numerically speaking. I want to say it's 2.5. I think anything above a 2.5 is considered an overexpression of BCL6. Don't quote me on that number, but it actually doesn't matter what the number is. So your number could be 7 Or if the threshold is 2.6, your number is 2.7. It could be zero point 0.1 above, or it can be several points above. You still treat it the same. There is no evidence that prolonging that treatment improves the outcome there, at least in that I'm aware. Now, again, every doctor has their own way of doing things, but from the evidence-based approach, that much I can tell you. But I'm glad that you did the test, Sarah, because now you know that you have it there, and it's something that you can treat that will positively affect your outcome. So fingers crossed on that one for sure. Rosa said, I had a second-degree tear with a vaginal birth using the vacuum. Will it ever go back to normal? Will it heal fully? I'm now 7 weeks postpartum. So the answer is yes, it does completely heal. There are really four levels of what we call obstetric lacerations. And that is the type of tear that happens to the vaginal skin, the skin of the perineum, and the muscles that make up the perineal body. Four different levels. Now, Rosa, you had a vacuum assisted delivery. And for those who don't know, a vacuum is literally a little suction cup that goes on the top of the baby's head that helps to bring the baby out of the birth canal in the last moments of labor, so that in order to expedite the delivery. Sometimes that happens because the baby's in some kind of distress, and we need to get the baby out. Sometimes it happens because mom is just exhausted and can't push anymore. But usually the vacuum is reserved for when the head is really right on the perineum, about to come out. And the idea of having to go back to the operating room for a C-section would take far, far longer than it would just with a few extra pushes, giving a little extra support from the suction cup to just bring the head through the vaginal canal. So that's what a vacuum assisted delivery is. The four layers or the 4 degrees of obstetric laceration. A first degree laceration really just tears the superficial skin in the vagina, what we know of as the mucosa. A second degree laceration tears deep below the mucosa and into the connective tissue underneath the vagina. Sometimes even with a first degree laceration, you don't even necessarily need stitches. Sometimes those can be small and superficial enough that they will heal on their own. With a second degree laceration, almost always you need some stitches to put things back together. Usually we really always now will use a biodegradable suture that will dissolve on its own. But Rosa, it does take probably really at least about 6 weeks for that suture itself to dissolve. When I see someone back at the 6-week mark, or when I was doing OB and would see someone back at the 6-week mark for their postpartum visit, it was not at all uncommon that the area that was repaired after childbirth was still sensitive. It was still tender. It was still healing. I think it realistically, it does heal up very, very quickly. But by 3 months, my guess is you will probably no longer remember that you'll remember that it happened, but you should no longer really be having any symptoms from it at that point. So a third degree laceration tears down deeply enough so that it is starting to split apart the big band of muscle that sits underneath the tissue there that we know of as the perineal body. And that band of muscle is the anal sphincter. The anal sphincter is literally a round band of muscle, as you might imagine, and sometimes we do have to repair that muscle with childbirth, and that's what a third degree laceration is. A fourth degree obstetric laceration is when that anal sphincter has been completely separated and has to be put back together. That is a skill. It is a skill that all obstetricians are trained in. Vaginal surgeons are trained in, because doing that correctly means the difference between continence and incontinence of things like gas and stool later on. Sounds wonderful, doesn't it? Really makes you want to run out and have a baby. But fortunately, these are all things that obstetricians are well trained to be able to care for. So yes, Rosa, I promise you it will get better. Hey, it's half past the hour, which means it's time for us all to do the 5:30 Fuzzies with Fink. And I alluded to it before. What exactly does that mean? Well, I'll tell you. The world is not a kind enough place. I am always impressed when I see random acts of kindness, things that people do for one another that really bring a tear to your eye and really touch you in the heart. But at the same time, I have to say, the number of, you don't have to watch the news for very long to see how much bad news is out there, or to have to deal with too many people before you realize there are a lot of mean-spirited people out there who really aren't out for the best interests of anyone but themselves. Kindness is in short supply, and that's what we are here to send out to the universe right now. Especially at this time of year, folks can start to feel alone. And maybe you are alone in a crowd of people. Maybe you've experienced that before. Maybe you feel lonely because of the holidays or some loss that comes back to mind as a result of the holidays. Maybe you feel lost in this fertility conquest, is what it seems like, because the road can be so long and so bumpy. Maybe it's something with a relationship, or something at work, or something with family. This is the time that we all stand together as one community, sending out positive vibes. I always say, let's break the internet with the positive vibes right now to everyone who needs to know that they are not alone. And I would like to send a special shout out to Stephanie this evening, who is mourning the loss of her mom. This is a very tough time of year, and that only, it should be a joyous and happy time of year, but so many things can make that difficult. So special thoughts to Stephanie, and really to each of you who is going through whatever you're going through. Let us say right now, here we are to be together as one, to send out those positive vibes right now. Send them out right now. There they go. And I hope the internet just saw a big spike as a result of the work that we just did there. So at the end of the day, please do a random act of kindness for a stranger. Smile at a stranger, wave at a little child, give a child a toy or a piece of candy, or be nice to someone who you don't know, because you never know what they've just been through or what they're going through in their own lives. And I have to say here also, this group of people who tend to migrate towards my broadcast here are a very special group of people. And I know pretty much each and every one of you would go out of your way to help anyone else who is going through the same thing that you are here tonight. And so for that, I thank you, and I thank you for being part of the 5:30 Fuzzies with Fink. We'll do it again next time, but next time will be January the 6th. Nikki Jones has joined. Hey there. It's so nice to see you, Nikki Jones. Fit, haven't seen you for a while. Wanted to let you know we finally had our miracle IVF baby, who is now 6 months old. That makes me so happy, Nikki. Gosh, I am so happy to hear that. I have not, come to think of it, I don't think I've seen your Instagram for a while, so I'm going to have to go look at it and look for your baby pictures, but please send me one, would you? Congratulations. That is awesome. Rosa asks, I have an endometrioma on my ovaries, but when I did Receptiva, it came back negative. Is this possible? And the answer to that is yeah, absolutely. So First things first is that that Receptiva is not a perfect test, but it's highly correlated to endometriosis, and that number is about a 93% correlation. But here's the thing: everybody with endometriosis does not necessarily have a problem implanting a pregnancy. And maybe you have heard me talk about this before, but I can think of the days when I would do laparoscopy to, let's say, as a general gynecologist, to go and, let's say, do a tubal ligation. Maybe a lady has had 4 or 5 babies and she doesn't want that fertility anymore. She wants to have her tubes tied. So we put a camera in to go do a tubal ligation and look around, and holy cow, she is absolutely covered in endometriosis. And we say, oh my God, how did she ever get pregnant? How does she have a period without, feeling torture? This is so much endometriosis that I would think it's got to be debilitating, but she never had a symptom. Conversely, we may see someone like you, Rosa, who has a giant endometrioma in an ovary, but yet is BCL6 negative. That just means that endometriosis has not affected the endometrial lining. The endometriosis can do some other things. It can lower your AMH. It can lower the ovarian reserve. It can cause a pain syndrome. It can cause a giant cyst in the ovary that makes somebody want to do surgery on you. It can mechanically interfere with fertility, like by causing some scarring or doing some things with the fallopian tubes or the end of the fallopian tubes, which we call the fimbria. But as far as embryo implantation, that's when endometriosis creates a problem in the lining of the uterus. And if that BCL6 marker was negative, I would say that you didn't have a problem implanting. In fact, you got pregnant there because you just had your baby. So I don't remember if you did some suppression. Now, I might have been apt to say, gosh, you've got that big endometrioma. I'm going to assume that your BCL6 marker is positive. And so I'm going to recommend suppression for you for 60 days anyway before we put that embryo inside. I do not typically recommend the Receptiva test for folks with known endometriosis. So, for example, if I look with an ultrasound and see a big collection of endometriosis in your ovary, I'm going to say, why do we need to diagnose endometriosis in your lining? Because I know you have it in the ovary. I would have just treated you because of that. But yes, it's absolutely possible to have known endo and to be BCL6 negative. Hi to Daisy Dum Dum. I like the name. Reagan, good evening. Nice to see you here. Doc Snoozer, howdy. And Sarah says, yeah, absolutely. After my 2 euploid losses, I'm glad to have the embryo. Rather glad to have the information, and that information is the Receptiva test. Now, I have taken to, so, I will tell you, Receptiva was not originally intended to be something for the general population. So I wouldn't, everybody who walks into my fertility clinic, I don't say, well, let's do a Receptiva test to see if you've got endometriosis so that at least we know. In the olden days, and you may have heard me say this before, in the earlier days of reproductive endocrinology and infertility, a laparoscopy was a routine part of the evaluation. The doc I used to work with said you would have had your laparoscopy scheduled before you ever even met the doctor. So everybody got a laparoscopy looking to see if they had endometriosis. Well, it turns out that doing that procedure on all those people really didn't improve the pregnancy rates. And so they were saying, well, we got to do this for everybody. In fact, what it was doing was really testing for endometriosis. Testing for endometriosis in the general population does not improve the fertility rate. Now, I do offer the Receptiva test because in many ways, I think Receptiva can be superior to surgery. And the reason for that is, when we do a laparoscopy and look for endometriosis, the endometriosis that we see is really just the tip of the iceberg. There is always going to be more endometriosis than what meets the eye. And so even if you have surgery and have the visible endometriosis treated, I would still recommend that you do some suppression, because there is always a chance that there's more endometriosis there that we didn't see when we looked. And if that's going to be the case, then I'd say, why have surgery anyway? What's the benefit of the surgery if you're going to treat it medically? And now there are a lot of docs who were sort of brought up in that laparoscopy era. They love doing laparoscopy, and they will recommend that you have a laparoscopy to see, quote unquote, why you're not getting pregnant. I don't think the evidence supports that. And in my opinion, if you can avoid surgery, for crying out loud, avoid surgery, if you need surgery, then you have surgery, and that's the end of it. But I like that we can test for endometriosis non-invasively now. And even though that is not a test that is covered by insurance, it is often going to, and the reason for that is there is only one laboratory in the country who runs that test, the Receptiva test. The BCL6 test is a proprietary marker. Only one lab does it. And so, of course, they're not going to take insurance, because insurance will say, well, we're only going to pay you, $5 for the test or something. And they say, no, it cost us more to, develop this test. And so they can set the price for it. The price that they set for it, and I think it's $690, if I'm not mistaken, I believe, is still likely going to be less than what you probably have to pay for your insurance-covered laparoscopy. Why is that? Because we've got deductibles and we've got co-pays, and the surgery center wants their piece. The anesthesiologist wants their piece. The pathologist wants their piece. And so the bills just kind of keep coming in. You think it's going to be a one-time fee, but my guess is in most cases, people end up paying more than that for a laparoscopy, even that's going to be covered by insurance. And that's probably how they came up with that price point for the Receptiva test. So just my 2 cents worth there. Angela asks, would Receptiva be accurate if the biopsy on cycle day 14 or 15 instead of 7 to 10 days after ovulation? Potentially not. So it could be, but first things first is there are 2 types of endometrium. There is the proliferative type of endometrium, and that is the uterine lining. That's what the uterine lining looks like under the microscope in the first half of your cycle. The second half of the cycle, that lining is called secretory. Secretory endometrium, like it's secreting something. Secretory endometrium. A Receptiva has to be secretory endometrium. And the reason that they select 7 to 10 days later after ovulation, because that's the time that your embryo would normally be implanting, right? So they want to know, are you expressing the BCL6 marker at that time that the embryo would implant? So they recommend that you test it not on cycle day 14, but usually between cycle day kind of 21 and 24. If the biopsy test, Angela, came back and it said it was proliferative endometrium, then the result of that test is not accurate for you. All right. And that's really a very important thing to know. That should be incumbent upon your doctor, but depends on how well they understand the test. Day 21 to 24 is the best time to do it. Heavenly Joy, thank you. And Harold Fink is here. My gosh, we've got both the Bama Gal and Harold Fink. How is that even possible? Harold is my wonderful, beautiful father in Mobile, Alabama, who turns 88 this year. God bless you, on the day after Christmas. And so we are looking forward to having some celebration with you, sir. Let's see. Rosa says, I have 2 aneuploid embryos, a plus 15 and a plus 16 male. Is there any hope to transfer of those? Have you seen live births from it? So that's a trisomy 16 and a trisomy 15. So first of all, PGT testing is not perfect. Very much so, PGT is not perfect, and there is anywhere from a 5 to a 15% probability that a an embryo that is said to be abnormal on PGT is actually normal. So, have I seen people transfer PGT embryos, PGT aneuploid embryos, and get pregnant? And the answer is yes. Yes, I have. In fact, we had a lady who transferred two aneuploid male embryos because she was sure that she wasn't going to get pregnant, but she wanted to do it at the right time anyway, didn't feel good about destroying those embryos. So we transferred them just at the right time, just to kind of see what happened. She ended up having completely normal twin boys. So, yes, it absolutely can happen. It does happen. The first thing I would say is that we would want you to have a consultation with a certified genetic counselor so they can talk about what does trisomy 15 and trisomy 16 mean. Now, the ones that we typically do not transfer are the ones that say trisomy 13, trisomy 18, and trisomy 21. Because most of the other, what we call autosomal trisomies or abnormal chromosomes that have three chromosomes instead of two, most of those other ones, if they were to implant, are not likely to continue to grow. So if there was truly a chromosomal abnormality in the embryo, what we'd be worried about is potentially that embryo continue on to result in a live birth. And I have never seen that happen with a trisomy 15 or trisomy 16 embryo. Those, if they're real, they're just not compatible with life, and so the embryo won't continue to grow. But trisomy 13, trisomy 18, trisomy 21, Down syndrome, those embryos can continue to grow and result in a live birth. And that's the sort of thing that we don't want to have happen to you unless you are prepared for that. There is nothing wrong. Down syndrome kids are the sweetest kids, and they can live very fulfilling lives, but they often and usually require a lifetime of care. Trisomy 13 and trisomy 18 can result in a live birth, but typically the babies don't live for more than a few hours, and that is really a heartbreaking thing to go through. So those are the things we try to avoid. So usually we say if we're going to transfer an aneuploid embryo, then we want to know for sure that you have talked with a genetic counselor and have a good understanding of what those aneuploidies mean. So, hi to Melissa and Lelix, Nina Buena. Hello there. Good evening. Heavenly Joy. It's nice to see you here. Let's see. Angela comes back and says, I had my Receptiva biopsy done during my retrieval since I was under anesthesia. We do not, and underscore do not recommend that you do that anymore. I too have done that, but I do not recommend it because the company is very explicit that if done during the time of embryo or of egg retrieval, there is a much higher probability of a false negative or a false positive result. So I would not offer that. I do not offer that for that very reason. And part of that is also, it's more likely, potentially a false positive because the medications that we use for stimulation, egg stimulation, are said to potentially result in false positive results there. So I don't know, Angela, if yours was actually a positive or a negative, but I would not consider it accurate if done at the time of an egg retrieval. And yeah, I too used to really prefer to do it, when you're under anesthesia, because who needs to feel that? It's no fun. It's uncomfortable. And so we're kind of trying to keep you from having some discomfort and pain by doing it with anesthesia. However, explicitly not recommended by the manufacturer. Heavenly Joy says, I've been on a long break from IVF due to 3 times of failure. Starting next year, how do I prepare my body? Well, so the first thing is I would say, there is an evidence-based protocol for what can a handful of vitamins do. I'm not sure, Joy, if you are talking about you're going to go back to doing an egg retrieval, or if you are going to be doing an embryo transfer. So there are different protocols for each. There is an evidence-based protocol for general egg quality for those with diminished ovarian reserve, and there is a specific protocol as it pertains to embryo transfer. So I think it really kind of depends on on what you are planning to do there. As far planning, thank you for answering. Planning to do an egg retrieval. So if you would like to email me, I'm happy to send you that list of the evidence-based protocol for supplements. From the standpoint of what else, kind of in general, can you do for your body? I would say that the most important thing is to try to clean up your diet. Diet, I really do think, has a lot to do with our fertility outcomes. Why is that? Well, because it's the easiest way that we get things into our bodies. The best way to message me there is through Instagram, and that's Randy Fink MD. Just instant message me. Give me your email address, and I am happy to email you with that list. But so, there are definitely chemicals in the water. But there are chemicals in the food that we eat. There are hormones in the food that we eat. There are things that cause inflammation in the food that we eat. So in general, I recommend that we try to clean up our diets as best we can. Well, what exactly does that mean? As you probably know, there is a lot of noise, and I'll call it noise because that's what it is, in the fertility space about, oh, you should be doing keto, and you should be doing carnivore, or you should be doing this, or you should be doing that. You should be taking acai berries. You should be drinking extra orange juice. You should be, this gummy or that gummy, and you should be spending, $150 a month on your prenatal vitamin. All that stuff is bupkis, I think. There is no one diet that has been shown to consistently improve outcomes. Now, the one thing that all the diets, and I personally recommend a Mediterranean diet, but the one thing that all the diets have in common is that they are low in carb. They limit your carbs because the carbs are pro-inflammatory. We know that carbs cause problems. They add weight to us. They add fat to us. That increases our cortisol levels. That also affects the way we metabolize hormones. Weight can definitely be associated with pregnancy outcomes. And so I think to the extent that we can eat clean leading up to that time is probably a good thing. Well, what's the sweet spot? The same thing as the sweet spot for using the supplement protocol, and that's in the 2 to 3 months before you start your stimulation and do your egg retrieval. That's what I would recommend. Again, I personally like the Mediterranean diet. I think that, it has been well proven as far as heart health, cardiac health, that it's useful. It's pretty easy to follow. You don't have to, kind of go crazy and dramatically change your eating habits. Everybody has a different opinion on it, but I would encourage you to not just listen to opinions because they're loud, they're vociferous, but look at the data behind each of these things. And I think you'll see there is no one diet that has been shown. In fact, really things like keto and carnivore, there's some evidence even to show that it can harm egg quality. Now, I don't know that I necessarily believe it because again, there are benefits to all these things, but you do whatever is what you can do. And nobody can guilt you into anything just because you didn't follow the diet that they said that you have to follow. So limit your carbs. That's the best thing. Carbs are pro-inflammatory. And so I'd say, yeah, you want to do that. Let's see. There was another question here about, and actually, Joy, you said you had a low BMI, and that also can really have something to do with things. We want to be optimum. A low BMI can also be associated with hypothalamic or pituitary dysfunction, which is the hypothalamus and pituitary are the directors of our hormones. So really what we're looking for is an optimum BMI. And that's, it kind of depends on where you are. And I'm happy to talk to you about that offline, Joy. Let's see. LabCorp did not give a result for Receptiva. That's correct because it does not come from LabCorp, but they did check for a CD138. It was positive at 17, which didn't make sense because I just finished 14 days of Cipro and Flagyl 2 days prior. Okay, so CD138 is a marker for chronic endometritis. What is chronic endometritis? Well, it is this situation where you've got this smoldering inflammation in the uterine lining. So maybe you get some bacteria that works its way up there. And the body says, wait, you're not supposed to be here. And so it turns on the fire extinguisher. But instead, and that fire extinguisher does a good job. It keeps you from getting an overt infection. And an overt infection would, probably result in things like, severe abdominal pain and some yucky, discharge that's like pus and maybe a fever. That's an acute infection in the uterus, and that can actually be pretty dangerous. But that chronic infection happens when the immune system is able to sequester whatever's causing it and partially put out the flames so that all you have are just some kind of little burning embers in there, if you will think of it like that. They diagnose that by the presence of what are called plasma cells. Plasma cells are the immune system marker for chronic endometritis. It means there's a chronic inflammation there. And when they can do a special stain for those plasma cells, and that's what's called CD138. That's what the stain is. When there are 5 or more plasma cells per high-powered field on the microscope, so they're looking with their strongest lens, 5 or more of those plasma cells that have been lit up by the CD138 stain or dye, then that's what we call chronic endometritis. Now, there are some people who are just colonized. They have a chronic inflammation that really doesn't go away. I typically now do recommend a test of cure for chronic endometritis before doing an embryo transfer because the evidence shows us, and I never used to do that. I used to say, we'll treat it, then you're as good as done. Nobody likes having that biopsy. It doesn't feel good, but let's just leave it at that. But what we know now is there actually is pretty good evidence that shows that testing to make sure it's gone improves the pregnancy outcomes. So I do recommend that. LabCorp or Quest or any pathology lab can do that test for CD138, and that is usually covered by your insurance. So there is no reason that you have to have that CD138 done for an extra out-of-pocket cost with your Receptiva test. So save a little money there. Let's see. Can you do this comes from Rachel. Can you do a saline sonogram and a histogram in the same cycle? Well, a saline sonogram allows us to be able to look inside the uterine cavity and to see that there are no big, what we call filling defects, which would be things like a polyp or a fibroid or a band of muscle or something that could prevent your beautiful embryo from being able to implant. We can see that with a hysteroscopy or with a saline sonogram. Now, when you say histogram, not sure what you mean by that, but if it is a hysterosalpingogram or an HSG, that's the test that is used to tell that your fallopian tubes are open. And yes, my practice was always to do the HSG and the saline sonogram at the same time, because the HSG, while it does light up the outline of the uterus to show us the shape of the uterus, it's really not so good for identifying small problems that are on the inside. So that's why I think a saline sonogram is useful at the same time as an HSG. Hey, Carrie, thank you for being here this evening, and Merry Christmas to you, folks. We are out of time tonight. Gosh, Santa is on his, well, he's not on his way yet, but he's getting ready. He's definitely getting ready. I wish you all the very, very happiest of holidays. My hope for each and every one of you is that 2026 brings you everything that your heart desires. Because, as it pertains to this fertility thing, this fertility story is not the book of your life. It is just a chapter. And I'll be damned if we aren't going to rewrite that chapter together, one day at a time, every step forward with kindness, every step forward with love, and every step forward with hope, because tomorrow is a new day full of all new adventures. So until January the 6th, when I'll see you again, thank you so much for being here. Merry Christmas, Happy Hanukkah, Kwanzaa, Happy New Year, whatever you're celebrating, we are all here to celebrate together. I'm Dr. Randy Fink in Pensacola. Good night. See ya.